This 86-year-old man presented with a colonic obstruction and was referred for pre-surgical decompression. Colonoscopy reveals this near-obstructing sigmoid mass. The first step in stenting such a stenosis is to pass a wire safely through the area. One method is to impact an inflated balloon catheter up against the stenosis and inject contrast to identify the channel. Then a glide wire can be passed under direct visualization. In this case, however, the wire passed easily through the stenosis without balloon catheter assistance. The balloon catheter is then advanced over the glide wire and a contrast injection is performed. Contrast flows along the folds of the colon, confirming the intraluminal placement of the balloon. The balloon is insufflated and then gently pulled back against the upstream margin of the stenosis. With the endoscope positioned near the downstream margin of the stenosis, the space then between the scope, marked by this first arrow, and the insufflated balloon, shown by the second arrow, provides a rough estimate of the length of the stenosis. This maneuver clearly identifies the position and the length of the sigmoid stenosis, which determines the length of the stent to be used and localizes the midpoint of the stenosis, which will be critical when deploying the stent. We like to have at least 1 to 2 centimeters of stent exposed both above and below the stricture following deployment, and thus a 5 centimeter stricture might require a 9 centimeter stent. In this case, the length of the stenosis appears to be about 2 to 3 centimeters, and thus a 6 centimeter length stent was selected. The guide wire is then passed up through the balloon catheter, which is then removed, leaving the wire in place. The assembly is then passed over the wire and up through the stenosis. Once positioned in the midpoint of the stenosis, the stent is slowly deployed by pushing the packaged stent out of its restraining catheter. Deployment results in stent shortening in some stents, as demonstrated here, so positioning adjustments need to be made during the slow and careful deployment. The process of deployment is observed both endoscopically and fluoroscopically to ensure proper positioning. If a major positioning change is necessary, most metal stents can be recaptured by retraction of the stent into the restraining catheter, as long as only partial deployment has occurred, as is demonstrated here. Returning to our patient, the remainder of deployment is observed endoscopically. Following full deployment, there may be a rush of fluid or material from the upstream obstruction. When cleared, the stent lumen can be viewed. Fluoroscopically, the stent is visualized. The waste created by the obstructing mass is easily seen. It is acceptable that the stent slightly favors an upstream position relative to the midpoint of the stenosis, as colonic peristalsis will tend to shift the stent downstream slightly. Enteral stenting of the colon has been successfully used in a number of clinical situations. As in this example, the enteral stent decompresses the colon prior to resection of a malignancy, thus avoiding the need for a temporary decompressing colostomy. Similarly, in patients with sigmoid obstruction due to diverticular disease, the enteral stent can convert a 2 or 3 stage operation to a single stage resection. Enteral stents have also been placed in malignant disease as definitive therapy for end-of-life palliative care. And finally, there has been a more limited experience using these stents in the long-term management of benign disease, although only in selected situations.